Good evening to all of you. Uh, I welcome you all for this live webinar. The topic is ECG in the emergency room, part 2, a case-based discussion. Part 1 was held on 24th May. You all are aware. To moderate the today's webinar, we have a moderator, Dr. Smith Srivastava. Dr. Smith Srivastava is MD, PGDM, HHM, and DM. He is associate professor and head of Department of Cardiology. He is attached with Advanced Cardiac Institute, Pandit Jawaharlal Nehru Memorial Medical College, Raipur, Chhattisgarh. He is winner of National Gold Medal for Best Paper at Jericon 2009. He is fellow of American College of Cardiology. He is fellow of International Medicine Science Academy. He is fellow of Indian Society of Electrocardiology. He has number of publications in Indian Heart Journal, Journal of Indian Clinical and Applied Medicine. So I welcome you, sir.
Thank you.
Our today's speaker, we have two speakers today in this webinar. The first one is Dr. Javed Parvez. He is MD and DM. Is a consultant cardiologist, cardiac electrophysiologist attached with Ramakrishna Care Hospital, Raipur, Chhattisgarh. He is postdoctoral fellowship in cardiac electrophysiology and pacing from Jayadeva Institute of Cardiac Sciences, Bangalore. He has got a gold medal in general medicine from JJM Medical College. He has authored numerous national and international publications in accredited journals. It's a regular speaker at national and state conferences and has keen interest in arrhythmia interpretation and ablation and cardiac device implantation and intervention. His topic of today is focus on crucial clues adding clinical diagnosis. Our second speaker, so welcome you, Javed Parvez, sir. Now I also welcome our second speaker, Dr. Sanjay PV. Dr. Sanjay PV is consultant cardiologist and electrophysiologist attached with SRM Institute of Medical Sciences, Vadapalani, Chennai, Tamil Nadu. He got a Young Investigator Award from Asia Pacific PCR Singapore Live. Indian Heart Journal AV Award honor also for the best DM post graduate thesis in cardiology 2016. He has his presentation done in National Eco Conference IAE Madurai, IHRS 2018 Jaipur. He has done presentation in national and international conference and has author of numerous publications. The topic today on which he will be speaking is interesting cases of Syncope. So these are two speakers for today's session, and moderator is Dr. Smith Srivastava. Before actually I hand over the session to Dr. Smith Srivastava, there is a surprise for him. Yesterday only we celebrated birthday of Dr. Smith Srivastava. So as a token of regards from all of us and from our good wishes, I request our technical team to play a video of just 39 seconds.
Rajiv, very thank you. It was a very beautiful presentation, and I think I'm feeling that it's another day that celebration continues. There is before we start, basically even Javed's topic is also on Syncope, because last time most of the audiences they requested that we need something on Syncope, so both of the speakers would be speaking on topic on Syncope. So I'll request Dr. Javed to begin his presentation, and we'll learn a lot from him like last time we did.
Okay, thank you, sir. Let me start sharing my slides. Okay. I think the slides are visible. Okay, so before beginning, I must thank Dr. Smith and Dr. Sanjay the, uh, for uh, for joining me on this presentation. And despite we had multiple reschedulings, and Sanjay and Dr. Smith both persisted with me in this endeavor to bring to you this presentation on ECG and syncope. So again, like the last time around, we have divided into two parts. The first part, which I am going to be covering, covers a lot of theoretical aspects, and then I'll be showing some 4 to 5 interesting cases of syncope, where ECG was vital in arriving at various clinical decisions. And then Dr. Sanjay will take over, and he will show his interesting cases collection where of syncope where ECG was involved. So without much further ado, let us begin, because I have a history of overrunning my time during presentations. Okay. So first of all, a definition of syncope: a transient loss of consciousness due to cerebral hypoperfusion, which is characterized by rapid onset, short duration, and spontaneous complete resolution. So I'll be spending just 1 minute on the definition, because the definition is really very, very important. One needs to understand that before labeling any patient with syncope, we need to have complete transient loss of consciousness, and we are attributing this loss of consciousness due to cerebral hypoperfusion. And there are these three characteristics features, that is, the onset is rapid, and the episode is of very short duration, and spontaneous complete resolution. If all these four are present, then only you label any patient with transient loss of consciousness as having syncope. And also very important to remember is that the syncope is not a is not a diagnosis; it's a symptom. Now, what are the steps in evaluation of syncope? Basically, we'll be dealing with the importance of ECG in syncope. But before we go there, it would be good to revise how to evaluate a patient with syncope. So, step number one would be to confirm that the episode was a definite syncope. So, we must differentiate it from syncope mimics, syncope-like events which were not syncope, and I'll come to that, and history. So as I will show in subsequent slides, out of all the things available to us to come to a diagnosis in a case of syncope, history has an yield of almost 30 to 40%. So as from my experience that I am running a syncope clinic in my hospital here, we need to devote at least 1 hour to find out what were the precipitating factors, what was the patient doing at the time of syncope, what was his, were there any triggers, and were there any medications which were responsible, what was the situation like, and how were his limb positions at the time of syncope, was there any involuntary movements or involuntary loss of urine or tongue bite. All those things are very, very important. So it is of utmost importance in every patient with syncope that we tend to devote some time to history. Then similarly, physical examination, ECG, all the efforts in any patients with syncope are devoted to basically to find out whether the syncope is malignant or not, or whether we are dealing with a structural heart disease or neurological disease or not. And when it comes to ECG, our all efforts are devoted to find out whether the patient has a structural heart disease or not. Then, further guided by our history and physical examination, we go for further tests, which can be neuroimaging to echocardiography, depending upon case-based scenarios. And then comes after basic evaluation, we still don't have any diagnosis, so we label it as unexplained syncope, and then it becomes a specialized field, and then we need to consider specialized tests like maybe tilt table test and implantable loop recorder. You'll see the utility of all in subsequent slides. So now, as I was saying, that we need to differentiate syncope from syncope mimics. So if you have a complete loss of consciousness, loss of postural tone, and very rapid onset of transient loss of consciousness and complete spontaneous recovery, then we are very highly likely that you are dealing with syncope. While there are certain similar sort of episodes where there is no loss of consciousness, for example, a TIA of carotid origin, falls, or cataplexy, there we don't have impairment in consciousness. And when we cannot differentiate just based on the history, then probably we should not label the event as syncope, or you can label it as query syncope, or label it as just simple false, so that it becomes easy for subsequent evaluation. Similarly, you have metabolic disorders like hypoglycemia, electrolyte imbalances, hypoxia, where you have partial or complete LOC without global hypoperfusion. So we have LOC, but you are not attributing this loss of consciousness to global hypoperfusion. Once again, you should not label these patients as syncope. Now, most important differentiation is between seizure and syncope. This is a common problem that we need everyone faces. So, there are a lot of different things from which we can come to a differentiation whether the episode was a seizure or a syncope. All of these things are common and known to everyone. What I would like to highlight is usually you will have an prodrome which will be longer in seizure, and the prodrome of a seizure is different from a prodrome of a vasovagal syncope. Then comes loss of consciousness. It is very important to understand that you can have certain tonic-clonic movements or convulsive posturing even during vasovagal syncope or cardiac syncope. The difference here is that the convulsive episodes or the convulsive movements occur after loss of consciousness has occurred in patients with vasovagal syncope or cardiac syncope. While in patients with seizures, the usually loss of consciousness is delayed. First comes the seizure, or it is simultaneously with the seizure as well as the tonic-clonic movements. So it is not uncommon to have tonic-clonic movements during syncope, and these sort of patients are called as convulsive syncope. So it's very important to differentiate these two. Then all those things like tongue bite, again, it's an important point that tongue bite is rarely seen. Almost I see 100 patients of syncope in a year, and I have rarely seen a patient with tongue bite with patient of seizure with tongue bite. Similarly, incontinence, again, it can be seen with syncope as well as seizure. So it's not very helpful to differentiate. Similarly, the color of the skin, which is pale, and post-ictal state. Usually the post-ictal state in patients with syncope is very short and the recovery is very fast. But in elderly patients, even with vasovagal syncope, it may take hours to have a complete recovery. Just a moment with pathophysiological basis of classification of syncope. So the syncope can be of three major types. One is reflex syncope, cardiac syncope, and the syncope secondary to orthostatic hypotension. At the heart of syncope lies global cerebral hypoperfusion, as I've underlined earlier. Then you can have in cardiac causes of syncope, arrhythmias or structural heart disease, where you can have low cardiac output, basically contributing to low blood pressure and cerebral hypoperfusion. While in reflex syncope, all the cardiovascular reflexes which are responsible to maintain cardiac output and blood pressure and cerebral perfusion are defective. So you can have a vasodepressor kind of response where sympathetics are involved, and you can have a cardioinhibitory type of response where basically parasympathetics are involved, and bradycardia asystole are the common presentations. Then you can have syncope secondary to orthostatic hypotension. Again, it is because of either structural damage to autonomic nervous system, or you can have the damage which is because of drug induced. So again, the causes of syncope are usually neurally mediated, orthostatic, arrhythmias, and cardiac structural pulmonary. Out of these, the most common one is neurally mediated, accounting for almost 40% of the cases. Then cardiac arrhythmias and structural cardiopulmonary problems almost contribute to 10 to 15, 20% of the cases. But it is very important to recognize these 10 to 20% of the patients, because these are the cases of usually malignant syncope where the chances of loss of life are much more rather than in a reflex syncope. So there are certain red flag signs. If you have any of these signs during any point in evaluation of syncope, you should either give more importance to the patient, and you should probably do an evaluation in an inpatient setting. So if you have structural abnormalities like low ejection fraction, decompensated heart failure, prior myocardial infarction. Now this is very, very important, prior myocardial infarction. In a patient who has history of documented coronary artery disease, if there is a documented syncope, you must assume that this syncope was because of VT or VF until unless proved otherwise. I have seen numerous occasions and numerous cases where a patient who had underwent angioplasty and was shifted out from the ICU had a syncope and was discharged and then brought in dead, with sudden cardiac death. So probably that syncope is the only syncope, or pre-syncope is the only initial red flag sign which can tell us that this patient is likely to have arrhythmia. So prior myocardial infarction with syncope should be given paramount importance. Then if you have a syncope during exertion, it should be given very utmost importance. Usually it is seen in outflow tract obstructions, or can be seen in CPVT or some forms of LQT as well. Syncope while supine. So most of the cases of reflex syncope are usually seen in standing position. So if you have syncope while supine position, you should give it much more importance if there is history of sudden cardiac death, and of course if there are ECG abnormalities, anemia, electrolyte derangement. Adding to that, if there is history of fall or trauma, significant trauma to the patient in any of these episodes, then probably it should be considered as a red flag sign. And if the patient doesn't have any premonitory symptoms or he cannot prevent a syncope, then it should be given much more importance. Now coming to the topic today, that is ECG in syncope. Again, there are a lot of findings on ECG and syncope which can help us to arrive at the conclusion of cause of syncope, starting from rhythm abnormalities, abnormalities of AV conduction, WPW syndrome, which reflect usually in the PR interval, this part of the segment. Then the QRS can tell us a lot of things about structural abnormalities. Then comes the ST segment, which can tell us about ischemia, certain channelopathies, then repolarization abnormalities like LQT and so on and so forth. So if you just remember just PQRST, this is just to give us a remember better what are the causes of syncope which can be found out on ECG. So from the rhythm point of view, first thing is sinus node and sinus node dysfunction. Again, sinus node dysfunction, to prove the patient has sinus node dysfunction is not very difficult. If you have a documented sinus bradycardia, which is inappropriate for the physiological circumstances, and the bradycardia is persistent and is not caused by drugs or any correctable causes, then you have proved that patient has sinus node dysfunction. The difficulty lies where when the patient presents to us with syncope and we cannot demonstrate a significant sinus pause or sinus arrest, and we just have sinus bradycardia. So in these patients, syncope is a common presentation of sick sinus syndrome, but the onus lies on the physician to prove that the syncope was clearly because of sinus arrest or pause. Just having sinus bradycardia on ECG and syncope, it doesn't put together 2 plus 2 is 4 and doesn't give us a conclusive evidence that sinus node dysfunction is cause of syncope. So again, other manifestation of sinus node dysfunction can be tachybrady syndrome, where you have alternating paroxysms of rapid, regular, or irregular atrial tachycardias, and slower atrial or ventricular rates. So this is an example of sick sinus syndrome. Here you can see we have an irregular narrow complex tachycardia, most probably a multifocal atrial tachycardia, and you have a long pause. The pause is almost 5 seconds. So if this patient presents to us with syncope, you can directly go for a definitive therapy in forms of pacemaker as well as antiarrhythmic drugs, because we know that 5-second pause can cause syncope. Suppose you have only 2-second pause or 1.5 to 2-second pause, and the patient presents to you with syncope, then we need much more evidence to say that the patient has symptomatic sinus node dysfunction and the syncope was because of sinus pause. So again, the same things I will highlight it again. In patients with syncope and sinus bradycardia and sinus node dysfunction, a symptom to finding correlation is a must. The onus to prove that the syncope was because of sinus arrest or pause lies on the physician. So you have to do prolonged monitoring, and that is the best way to prove these patients that the syncope is clearly because of sinus node dysfunction. In patients with sinus node dysfunction, electrophysiological study have very limited role, because most of the clinical decisions can be made by routine testing. And on electrophysiological testing, you can confirm that the patient has sinus node dysfunction, but you cannot produce a pause, so it is difficult. So one must remember before labeling something as pause on ECG, that if there are hidden PACs which are non-conducted, or if you have 2:1 AV block, as you can see on this ECG, it looks like a clear-cut 2:1 AV block on Holter. But when we did an electrophysiological study for this patient, what we found out was that there were junctional ectopics, and these junctional ectopics were getting conducted into the AV node, retrograde concealed conduction, and causing the next sinus beat not to be conducted. So you see here, so these are the A waves. A waves, that is atrial contraction. So A is synonymous for P wave on the EGM. So this is the P, atrial activation. Then you have H here, and then we have V. So this beat has AHV, sinus beat, conducting to the ventricle. Next beat, what happens? We see here that this A, right there is not conducted. The reason is because this H here has come earlier and this is an ectopic. Similarly, the same ectopic occurs again there. So this patient probably would require antiarrhythmic drugs rather than pacemaker therapy for correction of symptoms. So one must be very careful in diagnosing something as a significant cause to look for whether there are non-conducted PACs or there are concealed junctional ectopy. And how does one we know that? So you need to do prolonged monitoring. Then only such such doubts will appear. And wherever doubts appear, I think the most useful test to do is an electrophysiological study. Now coming to AV block. We all know that AV blocks can cause syncope. What I need to emphasize here that you all must understand that it is the paroxysmal AV block or the intermittent AV block that presents most commonly as syncope. If you have permanent AV block and relatively good escape rhythm and 24 hours that complete heart block is running on and you have a certainly stable escape, that patient will not present with syncope. It is almost always paroxysmal AV block or intermittent AV block that presents to us with syncope. Then if you have 2:1 AV block and with syncope, in these patients, certainly EP study has a very important role. As you all know that 2:1 AV block can be vagally mediated, or in electrophysiological terms, it can be suprahesian or intrahesian rather than infrahesian. So if you have a physiological or a vagal AV block, which is 2:1, it is usually benign. So in these patients, electrophysiological study has certain role. Then comes bifascicular or trifascicular block. So if patient has a syncope, history of syncope, and you find out that on the resting ECG, there is a trifascicular block, then very likely that this patient had an intermittent high-grade AV block that had resulted in syncope. Now again, these terms trifascicular and bifascicular are usually confusing, and many of the authors usually avoid using these terms. Whatever is there on the ECG, you must label it as it is. That is, if you have a right bundle branch block and LAFB along with first degree AV block, you mention it as all three. This is the most common combination where you get a incomplete sort of trifascicular AV block, where you have right bundle branch, left anterior fascicular block, and a first degree AV block. So also along with that, you can have a second degree AV block. So if you have a second degree AV block with a bifascicular block, chances of this being an infrahesian block is much more common. So this is an example of a first degree AV block is there. Then you have right bundle branch block and you have LAHB. So if this patient presents to syncope, more likely that the syncope was because of a high grade AV block. Now what about left bundle branch block? So this patient presents to you with syncope. So you have a left bundle branch block, sinus rhythm, 1:1 AV conduction, the PR interval looks normal. So what are you going to do? Is there any role of electrophysiological study here? Definitely, after further evaluation, if you cannot find any significant cause of syncope and you think AV conduction abnormality is involved or AV conduction is responsible for the syncope, then you must subject these patients for electrophysiological test. So specifically, if you have HV interval in these patients more than 200, or you have AV block at cycles more than 400 pacing cycle length, then these patients should would go for a pacemaker. What about this? So this is nothing but short PR interval and delta waves, and this is a WPW syndrome. A patient who has this pre-excitation on baseline ECG and presents to us with syncope should be given paramount importance. Most commonly, these patients would have had an episode of atrial fibrillation with pre-excitation, that is a pre-excited AFib, that would have caused a syncope in these patients, and there is a risk of sudden cardiac death in these patients. So this is not benign, and all these patients should be taken very seriously. What about supraventricular tachycardias? Supraventricular tachycardias usually do not produce syncope. Exceptions are if you have atrial flutter or atrial fibrillation with pre-excitation, they usually cause syncope. Or if there is baseline LV dysfunction, then these patients can cause syncope. Ventricular tachyarrhythmias, we all know that they can produce syncope. Now, what about PVCs? So, patient had a syncope and on the baseline ECG, you found out PVCs. So, what is the significance of them? So, if you have pleomorphic or polymorphic PVCs, that is PVCs which are of changing morphology or multiple morphology, they indicate the presence of structural heart disease. If polymorphic PVCs are present, more likely that patient had a ventricular arrhythmia and that had caused the syncope. Also, if you have R1T PVC, they can produce polymorphic ventricular tachycardia, especially in the setting of acute ischemia, hypokalemia, and congenital long QT syndrome. If the PVCs are interpolated, that they are not followed by a pause, or they come just in between of the two RR intervals, they are more commonly associated with PVC-induced cardiomyopathy, that is heart failure just because of PVC. Then there are short coupled PVCs, especially Purkinje PVCs. They can produce idiopathic ventricular fibrillation. So if any patient of syncope has a PVC in the baseline ECG, it should be given paramount importance. Now have a look at this ECG. This is from a young patient who presented to us with multiple episodes of syncope, and you see the baseline ECG is almost normal. You have an RS-RDAS pattern in V1. Other than that, there is no significant abnormalities. Some ST segment flattening in 2-3 AVF, nothing much. But multiple episodes and on prolonged monitoring, this is on an implantable loop recorder. What we could find out that there was a PVC. You can see here, this is the PVC right there, which has triggered a polymorphic ventricular tachycardia here, and it was producing syncope. So again, an important point that longer you record in these patients with unexperienced syncope, you will be able to obtain a diagnosis. Then coming to ischemia, have a look at this ECG. There is ST elevation in AVR, and I think previous presentations you would have seen the ECG. It's a very important ECG. That's why I keep showing it again and again. So you can this patient presented to us with chest pain and syncope, and you had an anterior wall MI with ST elevation in AVR and V1 to V4, so a proximal LED or an LMCA occlusion, and then you can see that a PVC appeared here or an R1T phenomenon that triggered a torsades. So again, ECG finding was very important. That is ST elevation in AVR. So now again, have a look at this ECG. This is also from a patient who presented with history of syncope. So what we can see is that it does mimic, it does look like LMCA occlusion type of pattern. You have AVR ST elevation, which is more than V1, and on the other leads you don't have much ST elevation, but you have ST depression in V4 to V6. So this is kind of a mimicking pattern, which it is not significant here because the baseline rhythm is not sinus. If you can see here in V2, basically this patient is having flutter. So in presence of tachycardia, the findings which I have shown just earlier in the previous ECG of LMC occlusion, they don't stand that significant ground. So basically this patient had 3:1 atrial flutter, and the LMC occlusion pattern was mimicking because it was because of atrial flutter and not in sinus rhythm. Now again, there are certain pointers in ECG which point towards structural heart disease. So what are those? If you have pathological Q waves, so that indicates a scar, and if that patient presents with syncope, more likely that he had a ventricular arrhythmia. Then comes fragmented QRS. So fragmented QRS is this slurring which you can see here. If you have this kind of slurring at the end of QRS or just prior to the end of QRS, or you have notched S waves, or you have notched R waves, and you have RS-RDAS with ST elevation, all of these come together in fragmented QRS. So if you have fragmented QRS in baseline ECG, that indicates you have a scar. And this fragmentation is because of slow conduction in those areas. So once again, ECG itself will tell you that the patient has a scar, and that is the reason of a syncope in these patients. Then you have intraventricular conduction delays, left bundle branch blocks, epsilon waves, and left ventricular hypertrophy. So especially IVCD and left bundle branch block, if they are present in the ECG, most likely the patient has structural heart disease, and the cause of syncope was cardiac arrhythmia, most likely. So have a look at this ECG in a patient who presented to us with syncope. So what you can see is basically rhythm is sinus, 1:1 AV conduction, PR is normal. You have incomplete, you have RBB-like pattern here. You have R wave in V1, and what else you have is a slurred fragmentation at the end of QRS, which is nothing but epsilon wave. You have T wave inversion precordial leads. So this is nothing but ARVC. Now in hypertrophic cardiomyopathy, again in hypertrophic cardiomyopathy, you can have syncope because of two reasons. One is because of scar, which can produce arrhythmia. The other is LVOT obstruction. So have a look at this ECG where you can see there is left ventricular hypertrophy, very high voltages. And what you see here is there is a pathological deep Q waves in 1, AVL, V5, V6. You see how deep these Q waves are. So they indicate hypertrophic cardiomyopathy. So this sort of pattern is less commonly seen in India. We see much more common pattern is that is of T wave inversion, LVH with strain pattern that is known as. And but even this pattern, if you have a diagnosis of a structural heart disease. So this is the pattern which is commonly seen in India, that is apical HCM. You have these T wave inversions in precordial leads and left ventricular hypertrophy. Then certain inherited arrhythmia syndromes. Also, you can pick these on ECG, that is long QT syndrome, short QT syndrome, Brugada syndrome, and CPVT. So we'll see the examples of each. So this is a patient with multiple episodes of syncope and is a young patient. What is striking here is that the QT interval is very much prolonged. And also if you see in V1, you see the T wave alternance, that in every alternate beat, the T wave morphology is changing, a very high predictor for a Trossard. So long QT syndrome is basically channelopathies. Sometimes it involves potassium channels, sometimes it involves less commonly it involves sodium channels. And even the morphology of QT interval and T wave can tell you what subtype it is. But the most important thing to recognize is to identify the long QT interval. Then similarly, if you have short QT syndrome, have a look at this ECG. The QT interval is very, very short here, lesser than 360 milliseconds. And if you have short QT and syncope, most commonly the diagnosis is congenital SQTS, and the arrhythmia seen here is polymorphic VTVF. Then you have Brugada syndrome, which is commonly diagnosable on ECG, and basically you have a right bundle branch block type pattern, and you have ST segment elevation, which is cove type in type 1, saddleback type in type 2. And in both these two types, the ST elevation is more than 10 mm. If it is less than 10 mm, it is type 3. So if you have syncope with Brugada pattern, most commonly again, the arrhythmia would be polymorphic ventricular tachycardia, and it should be taken very significantly. Now CPVT. CPVT is also a disease, inherited channelopathy, and most commonly the syncope here is exertional, and the TMT is diagnostic here. So what we see on TMT in these patients is not only we can reproducibly induce syncope, and initially we have a bigeminal sort of PVC pattern, when exercise starts, the PVC starts appearing, and as the exercises progresses, the PVCs become in bigeminal fashion, and then you can have a bidirectional VT or a polymorphic VT. So in this patient, as you can see, as the exercise progressed, these PVCs became much more frequent, and one of those PVCs has triggered polymorphic ventricular tachycardia. So as as I'm doing these tests, that is ILR and head-up tilt table testing, I run a syncope clinic here. It is important. I thought it is important to discuss about tilt table testing. So tilt table testing is very important in patients with unexplained syncope. So this is not a very sort of a sophisticated test. It's a very simple test, can be performed anywhere. All you need is a tiltable table like this, and you should have some sort of protection so that if the patient develops syncope, he should not fall down. And you need to have a defibrillator standby, because many of the times patient develops VFib also, and we need to give a shock. So commonly, what are the uses of tilt table testing? The tilt table testing is required only in patients who have atypical vasovagal syncope. So if you have typical vasovagal syncope, clearly identifiable triggers, and the history is clearly suggestive that the syncope is vasovagal, tilt table testing is not indicated. Tilt table testing is only indicated when the vasovagal syncope seems atypical. So that what does atypical mean here? Atypical means that the symptoms, there is no clear-cut identifiable trigger. The symptoms are occurring in supine position as well, and the recovery takes longer. So these are labeled as atypical vasovagal syncope. To confirm that this is vasovagal syncope, you can do a tilt table so that many of the times patient has recurrent falls. So to assess the syncope severity, you can do a tilt table test. There you can find out whether the patient is having vasodepressor type of response or cardioinhibitory. Then if you have syncope of unknown etiology, also you can do a tilt table test. Here the value is additive. If you elicit a positive response, then it is suggestive of a vasovagal syncope but not diagnostic. Then the patients who have diagnosed vasovagal syncope, there is something known as tilt training. So you need to train these patients to avoid having this syncope, and what is the response of tilt training also can be assessed on tilt table testing. So this is one of our patients who was having, young female who was having multiple episodes of syncope, was diagnosed as epilepsy, started on anti-epileptic medications. This is during tilt table testing. You can see in the tilted up position, the patient is unconscious, And the characteristic sign is that as soon as you make the patient lie down, within 20 seconds, there is recovery of consciousness. So that is diagnostic of reflex syncope or vasovagal syncope. Just one slide about the implantable loop recorder. So you can see the yield of ECG. So the longer you record, more likely you are that you will be able to come to a diagnosis. So a 12 lead ECG is basically a record of 10 seconds majorly. Holter monitoring at the max 2 days. Event recorder can do a recording up to 7 to 30 days, while an ILR can do a recording up to 3 years. So if you have a patient who has very infrequent symptoms, but the symptoms are malignant, that is the patient had significant injuries with syncope, and there is no other diagnosis suggested by previous test, then you can recommend the patient for a loop recorder. As I was saying earlier, that this is the diagnostic yield of various things that are available at our disposal. So as you can see, history and physical examination, if done carefully and done nicely alone, you can come to a diagnosis in these patients by 30 to 40%. While if you see the diagnostic yield of ILR is 43 to 88%. So the longer you record, the longer you look for, you will be able to find a cause. And this is how the ILR looks on a on a chest X-ray. This is just a small thing which is smaller, maybe smaller to the size of a shaving blade, and it is done under local anesthesia. Very simple procedure, easy to do. So nothing much to be worried about. So with that backdrop, I think we can go on to the cases of syncope that I have to show today. And once again, as these cases will have some sort of history preceding them and an interesting ECG, and there will be a question so that, and there will be a poll running along with the questions. So you can opt for the options, whatever you think. We'll wait for 10 to 20 seconds to see the result, and then we'll discuss the ECG. And there'll be a lot of questions by Dr. Sanjay. So you'll be evaluating afterwards whether you have been attentive to my session or not. So starting with piece number 1. So have a look at this ECG. This is from a 58-year-old female. She had a pacemaker implanted, which is a single chamber pacemaker implanted 5 years back. She had LV dysfunction. The cause was probably rheumatic heart disease. She had some MR and she was on medical treatment for heart failure. And she has recurrent syncope since last 2 days. So she was on diuretics as well. So what happened? Just let me go back. Yeah. So these are the options. So how will you approach this patient based on the light of the findings of this ECG? That what you would like to do a pacemaker checkup for this patient? This is probably device malfunction, or you like to think, yeah, this is definitely malfunction. Let's put a temporary pacemaker inside, or you like to give IV magnesium to this patient. Have a look at this ECG. The poll I think has already started, and in between we'll discuss the ECG, and after 20 seconds maybe we can have the results. Okay, so what does the ECG show? The ECG shows paced rhythm. As you can all see that there are pacing spikes preceding all the QRS complexes, but not all. If you see here, this is preceded by pacing spike and a QRS. So this is a paced QRS again, paced QRS again, paced QRS again. This is also a paced QRS. Then you have 3 non-paced beats. Okay, then again a paced QRS, then you have a pacing spike, but no QRS following that. And then I think the later part of the ECG is not visible. It doesn't matter. Anyways, by this only, you should be able to come to a conclusion. So is 20 seconds over, I think?
Yeah, 20 seconds are over. And I think most have voted for pacemaker check device malfunction.
Okay. Unfortunately, this happened.
Take it bit in details more.
Yes, definitely. And this is from this ECG comes from our alma mater, that is Jayadeva. And the importance of this I'll show you in a couple of slides. So basically, even the residents who were managing this patient thought the same, that this is pacing malfunction. The reason was this, that this pacing spike was not followed by a QRS. So they all thought that this is pacing malfunction, but this is in fact something much more dangerous than that. So what I've done is I've just zoomed the image so that we can have a good look at the QRS and the intervals. So if you just try to attempt to make a calculation of QT interval in this patient, so this is the onset of the QRS there. This is the end of T wave. And you have to take an RR interval which is preceding to this QT. So if you make this measurement and you calculate the QTC comes to around 626 milliseconds. So basically, the patient had long QT syndrome, long QT, which was probably acquired because of diuretics. and the QTC was very much prolonged. And the formula for QT interval calculation, I think we have discussed in multiple such events. It is easily available, and this is the importance. You see, if I go back to the previous ECG, you can see the time here. The time is 5:09 in the morning, and these residents thought that probably this was pacing malfunction, which was basically physiological non-capture because of undersensing. So these 3 beats which you see here are nothing but a non-sustained VT run, and this is a pleomorphic VT. You can see the morphology is changing here. So this is in AVF, it is inferiorly directed, the next beat is superiorly directed, the next beat is again inferiorly directed. So at least pleomorphic NSVT run is there, and because these pleomorphic beats have a shorter amplitude, so many of the times pacemaker fails to sense this. So that's what happened. This PVC was not sensed by the pacemaker, which is functional undersensing, and the pacemaker tried to pace here, and it did not capture because it is occurring at the end of T wave of the PVC, and basically the syncope was here because of torsades, as you can see in the subsequent ECGs. And unfortunately, this patient could not be revived. And this is at the 6:50 a.m. So you can see within 2 hours, the patient landed up in refractory VF and could not be revived. And probably the correct response was to give IV magnesium. So in any such patient, if you see prolonged QT interval and syncope, history of syncope, the first thing you should do is administer magnesium. Don't do anything other than that. First, give IV magnesium 1 gram stat, then maybe check for electrolytes. Then if you are worried about pacemaker, you can go for a pacemaker checkup as well. But if you find QT interval being prolonged and history of syncope, remember this is rule of thumb, administer magnesium at once. That is the only thing that can save the patient's life in that time. So this is just to highlight that. We'll move on to the next case. Okay, this should be easy. So this is a 36-year-old male patient with history of fever and syncope during fever, and echo was normal. Have a look at this, good look at this ECG. You can start the poll now. And so your options are whether you want to activate the cath lab, you think this is acute coronary syndrome. And the second option is correct electrolytes. So you think this is probably hyperkalemia or some sort of dyselectrolemia. Then the third option is refer for an ICD. D would be a refer for a genetic analysis. So we'll wait for 20 more seconds. Until that time, what I'll do is I'll try to describe the ECG, what all things are seen. So this is basically sinus rhythm, 1:1 AV conduction. And what abnormalities we can notice clearly is some sort of ST depression in 2-3 AVF and ST elevation in V1 to V3. And this is concaving upwards type of ST segment elevation. Some ST segment elevation is also seen in AVR. So based on the light of these findings, what do you think it is? Do we have the results, sir? Okay, let them have a good look at this because I've already shown this. This should be easy, I believe.
So no one is objected for has opted for genetic analysis, but everyone is for 66% is for correct electrolyte and 33 is for AICD.
Okay, so that is the effect of, I think, Sanjay's previous talk on ECG and electrolytes. That's what I believe.
Yeah.
Okay. Okay, so this is nothing but the Brugada syndrome ECG, and the option here is because just now previous slides have shown this is ECG pattern recognition. There is nothing much to explain there. If you see this pattern, you have remembered this by heart, so you will be able to easily recognize this. So this is coving type of ST segment elevation more than 10 in V1 to V2. So this is type 1 Brugada pattern. This is a patient who is young, and the syncope occurred in a febrile episode. So as I'll show in the subsequent slides, that even with this ECG and this history, we can clearly come to the diagnosis of Brugada syndrome. We don't need a genetic analysis. So I've just put that there to confuse, but none of them opted for that. So clearly you can go with this ECG and this much history, you can refer this patient for an ICD. So Brugada syndrome is documented ventricular fibrillation or polymorphic ventricular tachycardia with a family history of sudden cardiac death or COVE type ECG in family members, or if there is a inducible VT with programmed electrical stimulation, or history of syncope, or history of nocturnal agonal respiration. So if you have all this or any one of these with the ECG pattern which we saw there, you have a clear-cut diagnosis of Brugada syndrome. You don't need a genetic analysis. And Brugada syndrome is diagnosed when type 1 ST elevation is observed after spontaneously or after either intravenous administration of sodium channel blocker, that is flecainide, in at least one right precordial lead placed in standard or superior position without requiring any further evidence of malignant erythema. So that's what the ECG is a pattern I've previously described. This is a sodium channelopathy. So basically, what happens is there is a change in dispersal of change in dispersal in between the epicardium to the endocardium, and that leads to type 3 reentry and polymorphic ventricular tachycardia, and you can see this Brugada, clear-cut Brugada pattern there. So many of the times I get a lot of ECGs with a lot of physicians asking me whether this is Brugada or that is Brugada or not. So I would like all of you to take a snapshot of this slide and keep it with you. So because there is nothing much to be described or to be explained here. So this is a pattern recognition, and most commonly this is confused with a partial RBBP or an incomplete RBBP. So this ECG clearly shows that if you take into consideration ST segment in V1 to V3, and we even just based on that, you can come to a clear-cut conclusion whether the ECG is fitting into Brugada pattern, or it is partial RBBP, or it fits into a right ventricular ARVC ECG. Now coming to third ECG, now this is going to be interesting. This is probably, I think, most interesting case that we are going to see today. So pay close attention. So this is from a 60-year-old male patient with history of recurrent syncope, most of the episodes during sitting position and not associated with perspiration or palpitation. Of late, the patient had noticed episodes while eating food, and resting ECG is normal, and 2D echo is normal. So the patient has normal LV systolic function. So I'll just summarize the history. So there is an elderly gentleman with history of recurrent syncope, and most episodes are occurring in sitting position, not in supine position. And the symptoms appear to be atypical for a vasovagal syncope, so that he doesn't have perspiration, he doesn't have palpitations as well. So we don't think that there is a tachyarrhythmia going on, but we still need to confirm. And something very characteristic which he mentions, that there are episodes while eating food and resting ECG is normal. Now I'll show you a couple of videos. Have a good look at them. So this is the gentleman. Again, this is case which is courtesy by Dr. Neeraj, who's my senior from Jaydeva. So have a look at this ECG. This patient was in the emergency ER, and we asked him to swallow a cup of water in front of us, and we just connected a simple monitor and have a look at the rhythm, what is happening. So this is the patient swallowing there. Now I'll zoom into the monitor, what the monitor is showing. So this is just the monitor. We have cut out the patient. Okay, have a look what happens when the patient swallows. So I think whatever happened was clearly visible. Again, have a look at it once again. So this is happening recurrently with swallowing. So we can start the poll now. So the questions for this case would be, this case demonstrates that this is a typical vasovagal syncope, and the treatment would be lifestyle modification and beta blockers. The second option would be that this is atypical vasovagal syncope, treat with a pacemaker. Third option would be it's a reflex syncope. It's not a vasovagal syncope. It's a reflex syncope, treat with a pacemaker. So you can start the poll now.
It's again 50% for third option, reflex syncope, which needs treatment with pacemaker, and the others are 25%.
Okay, so I think they've got this absolutely right. I'll go back to the video and show it once again. So what happened is nothing but that the patient, while deglutition, was showing that there were periods of asystole, long pause, sinus arrest or long pause. So this is just with swallowing water. So you can imagine what will happen if the patient takes a larger meal or a larger solid meal, and he was having recurrent symptoms. So this is nothing but deglutition syncope, which is a form of reflex syncope. So like reflex syncope, other examples would be cough-induced syncope, micturition syncope. So all those examples are very clear to us. And like in vasovagal syncope, if you have clear triggers like emotional stimuli or a stimuli of pain, or a sight of blood, as commonly happens in medical training, that when many of the patients, many of the students see blood and they faint. So common faint is vasovagal syncope, and reflex syncope examples would be, as I said, after a prolonged bout of violent cough, many of times patient tend to faint. So in that case, you need to treat the cough. And in micturition syncope, you basically try to relieve any obstruction which is there, and then you try to ask the patient to change certain change in lifestyle, that is try to pass urine in sitting position. How do you solve this problem? Whether when the patient is having syncope while deglutition, so you cannot ask the patient not to have food. So the answer here is to put a pacemaker inside. So this is the correct answer, what reflex syncope, and the treatment would be with a pacemaker. So what does the pacemaker do? If you simply put a pacemaker during that pause, or during that pause period of sinus arrest, there will be definitely atrial pacing at lower rates. And also in certain other pacemakers, like many of the pacemakers with Medtronic has this, that is rate drop response. So in many patients who have we have recurrent symptoms and vagally mediated bradycardias, where there is sudden decline in rate. So the pacemaker tends to protect against sudden decline in rate. So the typical response of sinus node is to exertion or to exercise is gradual acceleration or gradual deceleration. That's how you define sinus tachycardia, that it has a gradual onset and a gradual offset. So while if the sinus node is diseased, or if there is vagal hypertonia, that gradual response goes away, and you can have sudden drops of heart rate from 70, 80 to maybe 40, and that causes symptom during those periods. So so pacemaker can sort of prevent that rate drop response. As you can see here, this is sinus rhythm going on, A sense V pace, A sense V pace. Here there is a sinus bradycardia, then sinus pause. There was one beat paced atrial pacing as well as ventricle pacing at lower rate. As the pacemaker recognized that there is a loss of, there is a big fall in heart rate from here to here, it started pacing at faster rates. So this is based on a lot of algorithms. The basic purpose is to, not to have those sudden drops, to smoothen the heart rate throughout the heart rate variability throughout the day, and to prevent such episodes of syncope. So that patient, was saved. Is doing well with a pacemaker, and she was implanted with a pacemaker with an RDR, that is rate drop response. And that is not a common phenomena. Majority of the time, these reflex syncopes or vagal syncopes are benign. Very rarely you can have these sort of patients where reflex syncope or vagal syncope can still have symptoms, and they need to be aggressively treated. Now, fourth question. This is a patient with 60-year-old male with history of recurrent syncope. He has benign hypertrophy of prostate. He's on tamsulosin plus dutasteride for that. And there are no clear identifiable triggers. So basically, either an atypical vasovagal syncope or syncope of unknown cause. And the patient has normal LV function. And this is the presenting ECG. So in the light of this ECG, so first have a good look at the ECG. And maybe after 10 seconds, I'll go to the polling. You can switch on the poll now. So this is the presenting ECG, and then these are your options. So how do you approach treatment for this patient? So one of the things that we could do is do a diagnostic EP study. This looks like a sinus bradycardia, and this syncope is because of sinus bradycardia related syncope, or there may be sinus arrest, we don't know. Or this is a atypical vasovagal syncope. We need to do a tilt table test to prove whether this is vasovagal or not. Or we can straight away go and do a permanent pacemaker. What we believe that pacemaker will solve this problem.
Doctor, we have a full house for option 2, needs a tilt table testing.
Okay. So I'll show the ECG again. So this is the ECG. Maybe after seeing the ECG, they might change their mind. Okay, so we'll discuss the ECG. So what looks like sinus rhythm 1:1 AV conduction ECG is not so if you have a careful look. So so to make things easy for you, I have pointed out all the P waves which are seen here. So basically what is happening is this is 2:1 AV block, and the second P wave is falling on T wave. That's why you see such pointed T waves. So if you see such pointed T waves, if you see carefully in V2, the T wave is biphasic. So the biphasic T waves are always abnormal. So either there is a P wave hidden into them, or there is ischemia going on. So if you carefully map these patients, mark these P waves and carefully see, this is a 2:1 AV block and the conducted PR is long. Then you have right bundle branch block. So you have right bundle branch block and 2:1 AV block. So with this itself, I think if you go for a pacemaker, it's reasonable. So this is how sometimes a simple 2:1 AV block can mimic and fool us. So this was the other ECG from the same patient. So at this time, this was 2:1 AV block with left bundle branch block. So now you have another indication, that is alternating left bundle and right bundle branch block patterns. And if we monitor even longer, as you can see, we monitored him for much longer. And now you can see clearly that there is a high grade AV block. So there are more than two P waves, more than one P wave which is blocked. So this P wave is blocked there, this P wave is blocked. This is conducted with an LBBB. Then the next one is conducted with a right bundle branch block pattern. That indicates that the conduction system is diseased. Whether or not this patient had syncope or not, a pacemaker is still indicated. The last question for my talk. So this is from a 55-year-old male patient, history of recurrent syncope, and most of the episodes occurred in standing position. There is history of two falls, and LV function was normal. So middle-aged patient recurrent syncope, and syncope occurred in standing position. LV function is normal. So this patient underwent an Holter at some other center. And as happens commonly with us, I got just a snapshot of single page of Holter on this on WhatsApp. This was forwarded to me. And so based on the light of these findings, the physician asked me whether what should be the further approach for this patient. So I thought this is a good ECG because it demonstrates a very important point. So the questions are, how would you manage for this patient? Okay, so the first option is there is a definite indication of pacemaker. Second option is this patient needs a tilt table test. Third option is this patient needs a tilt table test plus minus pacemaker. So we are not sure about pacemaker, but he might need a tilt table test to further confirm or to further evaluate whether this was a vasovagal syncope or not. So these are the options, very simple options, I believe.
Most of them, 60% feel that it is a definite indication for pacemaker.
Okay.
And another 30% feels heart plus pacemaker.
Right. So that was the main concern of the referring physician, and many of the times we do see such ECGs or such Holter tracing where things look difficult for us. So I've simplified this for you so that I marked the P waves. So what you can see is there is definitely one blocked P wave, and the next P wave is conducted. The next to next P wave is also conducted. And what you have to understand is that I've zoomed in the time at this happened. So this is somewhere around in the morning, 5 a.m. So probably the patient was in deep sleep during this time. And you can see that the PP interval is quite long. If you see 1, 2, 3, 4, 5 boxes. So there is sinus bradycardia which is going on, and the conducted PR is shorter, and this next PR is even longer. So this is nothing but Mobius type 1 AV block, and there is like vagotonia as is evident from sinus bradycardia. So this brings me to the last point of the today's presentation. What about vagal AV block? How does one approach a vagal AV block? This patient had vagal AV block, and the correct answer was a tilt table test plus minus pacemaker. Pacemaker may not be needed in majority of the patient with vasovagal syncope. But in certain indications, certain patients, even with vagal AV block, pacemaker is indicated. We'd like to see them. First, we'd like to know how to differentiate vagally mediated AV block from bradycardia dependent AV block. So we need to understand that vagally mediated AV block usually will have sinus bradycardia. So you have sinus slowing during ventricular asystole, and as sinus acceleration occurs, there is resumption of 1:1 AV conduction. And the wide QRS escape is usually infrequent here. While in bradycardia dependent AV block, the QRS is almost always wide, that is escape. PR prolongation is usually not present, and sinus rate is usually unchanged or increased. So if you have sinus tachycardia with AV block, it cannot be a vagal AV block. It has to be a significant bradycardia mediated AV block, or in the other words, it has to be an infrahisian AV block. While AV block which is associated with sinus bradycardia, one must rule out vagally mediated AV block. Now this is again ILR trace from Holter trace, sorry, from a patient who had vaguely mediated AV block. In this patient, he was having recurrent symptoms. As you can see, there is sinus tachycardia 1:1 AV conduction. Then there is sinus bradycardia, still 1:1 AV conduction. And then there is a prolonged high-grade AV block preceded by sinus bradycardia, and sinus bradycardia is continuing there. But as sinus rate begins to accelerate, there is resumption of 1:1 conduction. So if these patients develop significant symptoms, or there is history of malignant syncope, that is patient has recurrent falls, significant injuries, or patient is in a profession that involves that endangers other people's life, such as driving or maybe flight attendants or pilots, then probably these patients need to be taken much more seriously. And in patients who had documented sinus vagal AV block with associated malignant injuries, pacing is still indicated. So these are the indications of permanent pacing in patients with reflex syncope. So if you have spontaneous asystolic pauses which are vagally mediated, or you give adenosine and you see there is the prolonged AV block and there are symptoms, then pacing has a class 2 indication. Otherwise, if you have carotid sinus hypersensitivity, that is patient is having recurrent syncope, symptoms, falls, injuries, you do a carotid sinus massage, there is a long 3-second pause, then again pacing may be indicated in this patient, which is class 2A. Otherwise, if none of these are present and there is tilt table shows asystolic tilt, again here pacing is not of that much importance. It is class 2B. So that is the benefit is uncertain here. In undocumented syncope, pacing is not indicated. So with that, I think I'll close my presentation. This is a quote from Sir William Osler, which I think fits very well in management of syncope. That is, you observe, record, tabulate, communicate, use all your 5 senses, learn to see, learn to hear, learn to feel, and learn to smell, and know that by practice alone, one can become an expert. So thanks. If there are any questions, I can take them. And this is our ECG group on WhatsApp. If somebody wants to join, you can contact the IPCA team, local IPCA team, which has been giving you the invitations, so that I can add you on to this ECG group. Totally dedicated group to ECGs only. There are no social messages exchanged here in this group.
So there are few questions that I'd like to discuss with you.
Sure,
one is like if you have a patient who has a high PVC load, say something like 20-25%, 15-20%, and has vaguely mediated bradycardias during sleep, how would you like to manage this patient? No syncope.
Okay. So there are 2 issues. There is bradycardia, which is probably vaguely mediated during sleep, and there are high burden of PVCs. So are there no structural, there are no other clues on ECG that this PVC, there is structural heart disease?
No, the echo is normal. ECG otherwise does not tell you that it is anything abnormal.
So, sir, I would like to know first.
Bariatric surgery. So it's one of my patients who had been having bariatric surgery done around 1.5 years.
Right, sir. So, sir, I think I'd like to see the morphology of PVCs. So there are PVCs which we know clearly that they are arising from certain locations like RBOT. So the PVC is in structurally normal heart. Then there are certain locations we know that if PVC is suggesting origin from these locations, probably has structural heart disease. So even though ECG is normal or echo is normal, we cannot rule out structural heart disease. First thing I'd like to do is to do a cardiac MRI for this patient, because load is 20%, which cannot be neglected. Anything more than 10% should be treated as significant. So cardiac MRI first to rule out any structural heart disease. Prolonged monitoring to look for whether NSVT is there or not. If cardiac MRI turns out to be normal, then we can offer ablation, first medical therapy, then ablation. If medical therapy doesn't suppress this, if cardiac MRI turns out to be abnormal, then probably you need to do a PET, and maybe then the treatment course entirely changes. And if asymptomatic vagal bradycardia seen in night, which is common, we see day in and out in all the Holters daily. So it doesn't need any special, I think.
Beta blocker to treat it, you are not concerned that it may aggravate the bradycardia at night?
No, sir. If the bradycardia occurring at night, symptomatic bradycardia is what we should be worried about. If a patient is receiving beta blockers, the first thing we'll like to see on follow-up whether the PVC burden has remained same or it has reduced. Or if the PVC burden has reduced, then what has happened to the sinus node? And whether the beta blocker is causing significant sinus node dysfunction or not. Then we need to take it from there. Because beta blocker, if suppresses this PVC, then it become an essential drug for this patient. And if beta blocker is causing significant bradycardia, then probably he'll need a pacing or he'll need an ablation so that he needs to be taken off beta blocker.
Your junior from SMS, Dr. Jogesh, is asking how sensitive and specific are smartphones?
Smartphones for detecting arrhythmia. I think there is one study regarding that app, which is from the Apple Watch. So it has been found to be useful for detection of atrial fibrillation. So that is what, in terms of scientific evidence that exists, it exists only for the app which is with the Apple smartwatch. I have not used it personally, and the rest of the other things are probably, I think, propaganda driven, and there is no evidence for them. Sanjay, you have any experience on those apps? I am not using an Apple phone, Apple Watch.
That was, as far as I know, and I have not been personally using them. But if people have an Apple Watch, they are somebody who feels they have an irregular heartbeat. I think they have the device where they can record an ECG, at least a single lead ECG. So an educated person probably could use them, where you want to know whether he's in AFib or he's having
or not
any symptoms during that period. Apart from that,
I think there is one study which I had heard of. I'm not remembering it, but there is one study which has been published that this is good enough to detect atrial fibrillation, silent episodes of atrial fibrillation.
There's a definite study where they have, confirmed that it can be used for arrhythmia detection.
Right.
That's published in one of the American journals. So it's a validated study. The last question for Javed is, how most of our audience are physicians. So what is the treatment for bradyarrhythmias? The drug treatment, not for pacemakers and other things. How they will manage it before shifting that patient to you?
So symptomatic, I think most of we don't have much drugs in our armamentarium to treat bradycardia. Only thing we have is I think orsipronalin, that is used for sinus node dysfunction, and I think there is one more which is from that theophylline group. I think theobid trial, which has been shown that it has of some use in patients who have sinus node dysfunction and cannot avail a pacemaker. But in otherwise, if you see AV blocks or symptomatic AV blocks, if you have symptoms, specifically syncope, I think there is no role of medical therapy because these patients are highest risk of dying. Paroxysmal AV third degree AV block with history of syncope. And other than that, sinus node dysfunction, the treatment, that is implantation of pacemaker to relieve symptoms. It doesn't prolong life, it doesn't prevent mortality. Only thing is if the patient is having sinus arrest or long sinus pauses, only then. Or chronotropic incompetence, it does improve. Otherwise, it doesn't. And most of these patients, even how long if you treat them on Elipentor or Cbest, I think it doesn't work. More or less later on, they develop symptoms despite this therapy, and they will require pacemaker implantation.
Probably other than the congenital heart blocks, most of them would be needing a permanent pacemaker. There you have to make a difference. If it's a congenital heart block, probably that those patients can be left, but they don't need the drug treatment also.
Yes, even in that scenario, I think there is a lot of research which has shown that all congenital complete heart blocks should be paced. So it's an area of debate, but that is one school of thought that is rapidly gaining, evidence.
So I think we move to Dr. Sanjay's presentation, which is also on Syncope. And now he has a tougher time because Javed has, taken the most of the limelight and explained. So questions, I hope that there'll be more.
Because I had to teach and now he'll quiz them. So I had to take more time so that they can answer his questions easily.
Dr. Sanjay, please.
Yes, sir. Yes, sir. First of all, thank you, Smith sir, Javed boss, and the IPCA team for running this show again successfully despite the many hurdles. So I think Javed boss and we've always enjoyed discussing ECGs and fine-tuning our knowledge. I think however old you get or however young you are in your medical life, you're always fascinated by ECGs because at the end of the day, there's definitely one new point which you will learn, be it a single ECG also. That's what I and we always tell all our students and friends that every ECG give it a fresh approach. Don't run through an ECG, be systematic, evaluate the patient, and go ahead with ECG. So I think the following there'll be case scenarios, and I'll run through them, and there'll be a question probably after each case. So and we will have the poll. So so we can go ahead. Yeah. So first of all, this is an 87-year-old male with advanced Parkinson's. So he has never had syncope the year before. Only for the past 1 year, he has had syncope 3 times over the past 1 year. And the syncopes are unrelated to posture. So the Parkinson's has been there for 10 years. 9 years, he was absolutely okay. For the last 1 year, 3 times head injury, unrelated to posture. So this is his baseline ECG. You can all have a look at the ECG. And this is my question. So the syncope is most probably due to Parkinson's. So refer him to a neurologist for better care. Would you do a 24-hour Holter? If the Holter is normal, send him home. Or would you do a diagnostic EP study? So I think from what Javed boss has told all of us, I think we should use that information to arrive at the answer. So just to highlight again, so he has had 3 episodes over the last 1 year. They're not very frequent episodes. So I think we've started the poll. So I'll just run through the ECG. So we know that this is sinus rhythm with 1:1 AV conduction, but there is definite right bundle branch block, and the axis is leftward. You are having AVL which is positive, so probably it's axis of -45. So it's probably a right bundle branch block with a left anterior hemi block, and the patient has come to you with syncope. So Smith sir, what about the poll?
Yeah, poll, they need, majority says diagnostic EP study, and 33% says syncope is because of Parkinsonism.
Yeah, so excellent. I think Javed sir has done a great job. So we definitely don't send him to the neurologist, because a syncope in a patient with a bundle branch block, be it left bundle branch block, right bundle branch block, particularly when you have a bifascicular block, you assume that syncope due to a conduction system disease. And Holter we wouldn't do in this patient, because we'd probably be normal anyways, because the symptoms are so infrequent, and we would send him home. So how does a diagnostic EP study help us? So this is a usual trace which we see in our diagnostic EP study. We put a catheter in the atrium. We put a catheter in the region of the His. So His catheter basically measures intervals across the AV node and the bundle of His. So this is the His signal, and this is called the HV interval, the time taken from the His signal to travel up to the ventricular signal. So in this patient, his HV interval was 70. So we have a cutoff of 55 milliseconds. So anything more than 100 without symptom is significant, and more than 60 with symptom is significant. So this HV interval is significant for this patient. So this patient, we had taken in for physiological pacing. This is short note on physiological pacing. So as we know, traditionally we put the RV pacing lead into the RV apex, and that has many disadvantages. You can have a pacing-induced LV dysfunction. So physiological pacing has come up in the fact that we can capture the conduction system and give the patient a normal physiological QRS. You can either capture the bundle of His, or you can capture the left bundle, the anterior, the posterior fascicle. So we took him up for conduction system pacing. This is a short video. You can see the lead with the sheath. You can see how the lead is penetrating the septum. And this is a sheath angio which shows that the lead has penetrated deep into the septum. And this is the final lead position which you will see. So this is the atrial lead. I'm sorry. Yeah, so you have the atrial lead and the His lead, left bundle lead there. So the advantage in this patient, we did a left bundle branch pacing. You can see the above the first ECG, the bipolar paced ECG, which in fact looks like a normal QRS, and the below was his pre-existing right bundle branch block. So giving somebody this kind of a QRS is professionally very satisfying, and you know that he'll definitely not run into pacing induced LV dysfunction due to dysynchrony. So this is the echo. You can see the pacing lead across the septum. And again, you can see the pacing lead across the septum. And you can see the pacing lead clearly running across the septum. So take home points, syncope. So when do you investigate with a diagnostic EP study? I would say not all syncope. You should definitely have a severity to the syncope. Syncope with any kind of injury to the head and multiple syncope. And definitely when you know it's not related to a posture, it's not vasovagal. And even if the ECG, if the echo, if the Holter, if the troponin, and everything might be normal, we look for additional things. You look whether the patient has a baseline bundle branch block, either left bundle branch block, right bundle branch block with left axis, meaning it's a bifascicular block. You have alternating bundle branch block, which Dr. Javed was had shown, and you have baseline prolonged PR interval, and you have something called masquerading bundle branch block also. So we'll just talk about what masquerading bundle branch block is. So it's you have two types of masquerading bundle branch block. It is the standard type is where you have right bundle branch block in the precordial leads and left bundle branch block in the limb leads. So usually with a right bundle branch block, in the limb leads, you have a deep S wave in lead 1, an AVL, and you have uh, uh, upright R waves in 2-3 AVF. So if you have loss of S wave in lead 1 AVL and QS in 2-3 AVF, you call it the standard masquerading bundle branch block. The precordial type, you have RBB pattern in the precordial leads from V1 to V3, and from V4 to V6, you don't have the RS pattern. You just have a dominant R wave. So this is the standard type of masquerading bundle branch block, which is very common among patients who have syncope and who present with the right bundle branch block. So you should always look for this. So this is a second case, an interesting case. So this was a 53-year-old female, hypertension, diabetes, on long-term thiazide diuretic. She had recurrent episodes of syncope for the last 2 days, almost 15 to 20 episodes, all hemodynamically unstable. She injured herself once, and no family history of SCD. So we were fortunately able to capture one such episode. So I'll show you 3 ECGs, and then I'll go on to the question. So this is a case study as such. So this is you can see it's a polymorphic VT, and you can also see after the polymorphic VT which self terminates, definite there is QT prolongation and very broad T waves. And thereafter, when the patient came back in sinus rhythm, you can see this is something which I always like to measure. From the peak of the T wave to the end of the T wave, there are studies which show even in congenital long QT syndrome or even in patients who have acquired long QT, if the peak of T wave to the end of the T wave is more than 100 milliseconds, the patient is at high risk of tossards. So this patient, her initial admission potassium was very low, and there was low magnesium. We corrected her almost for 15 to 20 days. And for periods, she would have episodes even with a normal potassium. So then we decided to put in a temporary pacemaker. But still, even with the pacing, you can see pacing at the rate of 100, the QTC has not normalized. It was 5-10 milliseconds, even with the normal potassium and normal magnesium. So then thiazides we had stopped. We corrected the electrolyte. We thought whether there could be an underlying channelopathy. So we a long QT. So we in fact started propranolol. Episodes continued. We put a pacing wire in the ventricle. Episodes continued. We in fact did a bilateral cardiac sympathetic denervation for this patient. The episodes continued. And finally, we did a atrial based pacing, and then the episodes started coming down. So this was the atrial pacing. We kept the atrial rate to that point where the QT interval shortened. So we kept pacing the atrium at a rate of 100, and then 100, I think it was 110. And we saw that the QT interval at that rate was relatively narrower. So this is the post pacemaker ECG. You can see that the QT, you can see the pacing spike before the P waves, and this almost at the rate of 110. And the QT interval had come down, and she was symptom free. So my question is, in this patient, she's a 58-year-old, is a genetic analysis warranted? Would you screen her for long QT genes? Yes or no? Yeah, I think, sir, we have any poll
Yeah.
results?
Just waiting for 20 seconds so that.
Okay, sir. So just to recap, this was a patient, elderly patient who came with a resistant long QT on the ECG with multiple symptomatic episodes. Prior to this, she was not symptomatic. Despite correction of electrolytes, she's had persistent symptoms. Only after an AI pacing and probably the combination of beta blocker and sympathetic denervation, probably all three in combination helped her.
Yeah. So we have the results. Yes is 66% and no is 33%.
Yeah. So this actually was an interesting case for all of us, and this case was it was there when we did our fellowship at my alma mater Jayadeva. So in this patient, we in fact went for a genetic study. The reason why we went is a couple of pointers, because the T wave morphology at some of those episodes we were able to see that there was some bifid T waves. There was a long T peak to T end, which is more common with some specific channelopathies, particularly the long QT2. And the response the patient had to the atrial-based pacing, we thought that most of events were because of a pause-related syncope. So we actually postulated that she could have, and we were fortunate to have got the positive genetic result. So, and post pacemaker, the patient did not have any further episodes. She was discharged and she was asymptomatic. In fact, this patient actually deserves an ICD, a dual chamber ICD, but because of financial constraints, we had to put her on a atrial based pacing. So, just a quick recap. So, we have the three most common long QT 1, 2, and 3. As we know, I'd like to direct your attention to the potassium channel. The IKS is involved in long QT1, IKR and long QT2, and these are two long loss of function mutation, and the INA in SCN5A is a gain of function mutation. And long QT1 is usually seen in with exercise. This particularly because IKS is responsible for shortening of the QT interval when the rate increases. Because of the loss of function mutation, as you exercise, the QT doesn't shorten, and the patient has symptoms only with exercise. Whereas in long QT2, you have it's a pause dependent torsades where you have prolongation of the QT interval at slower rates. So if you see, this is also helps you in managing these patients. So you know that basically there's no point in putting a pacemaker in a patient who has long QT1, because anyway he's going to have even longer QT at faster rates. But pacing is definitely indicated in pause dependent long QT2, and in specific LQT3 you can try QT definitely shortens with mixiltine. So that is the idea of a genetic analysis. One, you can actually, it is a pharmacogenomics where you know the genomics and you can titrate the therapy. And number two, you can screen your family members also. And one more important thing, long QT1, the highest risk, and it's most commonly seen in patients in young males less than 40 years, whereas long QT2 is seen in the reproductive age group women. They are at the maximum highest risk, and LQT3 is seen in elderly patients where the highest risk is there. So another short and important note on the T-wave morphology, there was just probably brushed through it. Long QT1 has a very broad-based T-wave. So as you know, in the action potential, the IKS is responsible for the early part of the repolarization, and IKR is responsible for the latter part of the repolarization. That's why in long QT1, where the IKS is involved, you have increase in the duration from the onset of the T wave to the peak of the T wave. So you have a very broad T wave. Whereas in long QT2, you have IKR is responsible for the latter half of the T wave. So you have a bifid T wave. And in fact, when you measure from the peak of the first T to the end of the T wave, more than 100 milliseconds, it's in fact a risk marker for sudden cardiac death. And in long QT3, you have a long isoelectric line followed by the T wave. So take home message, I would say electrolyte abnormalities in old age, probably in our patient, the episodes of hypokalemia just pushed her to the torsades. So channelopathies being unmasked by such electrolyte disturbances can occur, and genetic analysis is useful, one, to treat these patients with a particular type of pharmacotherapy and to also risk stratify the family members. So this is the third case. So there's another patient, post mitral valve replacement with a tricuspid annuloplasty. She had mild LV dysfunction with an LA size of 5.7. She was complaining of disabling palpitations and breathlessness, and she was started on Cardivas 3.125 half twice daily. The reason why such a small dose was given, because as you can see, there's a holter of the patient. All of you can look. You have episodes of probably ill-sustained fibrillation of flutter, and you have a sinus pause. So probably the treating physician felt that no need to give on a higher dose where the sinus pause would get aggravated. But she will definitely had disabling palpitation. She wouldn't tolerate palpitation. And so after 2 days, she complains of severe fatigue, and you can see this ECG. So I'd like all of you to have a look at ECG, and I want you to tell me, how do you treat this patient? So would you stop the beta blocker? And if the rhythm reverts to normal, no pacemaker, just send her home. Number 2, beta blocker with a dual chamber pacemaker. Number 3, beta blocker with a CRTP. So I think we can start the poll now. And just to give a background, the patient has mild LV dysfunction, EF of 40%, and she's very symptomatic for a palpitation. She's not able to tolerate her palpitation. So it's a classic tachybrady syndrome. What would you do? So just going on with the ECG, you can see that there are no P waves, and the baseline is absolutely flat with a regular RR interval, and there are no peak P waves. So from the last talk, 3 possibilities: either it's an atrial fibrillation with a complete heart block, or it's a slow junctional rhythm, or it's severe hyperkalemia with sinoventricular rhythm. The T waves are not peak, it's not severe hyperkalemia. So either it's a junctional rhythm or an AF with a complete AV block. So based on her background with those runs of flutters, so probably it's a AF with complete AV block. So let's see how do we treat, and let's see what you've decided. Smith sir?
Dr. Sanjay, the house is divided between beta blocker with dual chamber and beta blocker with triple chamber pacemaker. So
Okay.
And
so yeah. Okay, sir. So this is a common clinical conundrum which all of us face. So number one, I'm happy that all of you decided that we have to treat the patient with beta blocker. That's absolutely right. Number two, do we provide her with a dual chamber pacer or a CRT? The problem is in a patient who requires more than 60% of pacing and who has even borderline LV dysfunction, studies have shown that the pacing itself, because you're pacing the right ventricular muscle, the myocardium, the desynchronous contraction, the LBB which you're going to induce in that patient, can aggravate the LV dysfunction. So guidelines say that you are justified in putting a CRTP. So in this patient, we had discussed with the patient's family. She had atrial fibrillation, and that was a permanent AFib. So we're not going to treat the AFib with rhythm therapy. We are going to leave the patient in AFib. We in fact went for a left bundle pacing. So I'll show you why. So we put a backup. So this is the his catheter which we use as a marker, and this fluoroscopic view is a beautiful fluoroscopic view. You can actually see the tricuspid valve ring, and this is the mitral valve ring, and this is the RV pacing lead which we use as a backup, because the surgeon was actually insistent that he wants a backup RV lead. In fact, you actually don't need this backup lead also. Just this left bundle lead would be sufficient. You can see it going across the septum. In this LAO view, you have both the annuli in parallel facing you, and the septum is exactly perpendicular. And you can see that the lead has gone across the septum. And in the lateral view, dead lateral view, you can see this is the anterior sternum, and the septum is posterior, and it's posteriorly directed. So this is we had a very good result in this patient, and I'll show you. So we paste the patient in DVI mode. So the left bundle is capturing with the RV sensing. So we put in a dual chamber pacemaker. We didn't use the atrial lead at all because she was in AFib. And you can see you're getting a very narrow QRS. And this is the QRS in RV septal pacing. Though we achieved a good septal location, comparing this QRS with this, definitely you know that the patient is going to have better hemodynamic parameters with this kind of a pacing, where you're capturing the conduction system. So tachybrady syndrome, first of all, drugs for the tachy and pacing for the brady. Previous RV pacing alone can worsen the underlying LV dysfunction which these patients have. Physiological pacing is a viable option because number one, the cost is not more. In fact, we could have just used a single chamber pacemaker for this previous patient, just screwed in the left bundle lead to that single chamber port, and the patient would have done absolutely fine. Basically, the RV lead was only put because of the insistence of the surgeon, and the patient is absolutely fine. So this is another interesting case, a 58-year-old female with one episode of graying of vision. So she came to us with this ECG and graying of vision. So I'll just give you 10 seconds to go through this ECG. Sinus rhythm 1:1 AV conduction, probably an incomplete right bundle branch block. T inversion V1 to V3, QTC is normal. And so another ECG was recorded from her previous record, and there was absolutely no symptoms during this ECG. So I want you to look at this ECG and tell me, number one, is this Mobitz type 1 AV block, Mobitz type 2 AV block, or you need more data? Based on this ECG, I want you to give me an answer.
Dr. Sanjay, there are no takers.
Okay, so this is basically a 2:1 AV block, and it's very difficult to tell whether it's a Mobitz type 1 or a Mobitz type 2. Mobitz type 1 is the Winky back AV block, and Mobitz type 2 is the more severe type of AV block. With the 2:1 AV block, it's very difficult. You actually cannot say. It could be either of the one. So you need more data. So we did a TMT for this patient. So you can see this was her exercising on the TMT, and you can see the rhythm strip. So you have the heart rate is 112, and after the sinus rate of 110, and you have a drop P wave. And again, I'll show you this. It's more clear. So you can see this rhythm again. And after observing this, I want you to now tell me whether it's Mobitz type 1 or type 2. Or again, whether you need more data.
Dr. Sanjay, it's 100% for Mobitz type 2.
Yeah, so I think they got the information that there's definitely no progressive increase in the PR interval. The PR interval is fixed, and you have a drop P wave, and this definitely Mobitz type 2. So we did a Holter because this patient's symptom was just a graying of vision. There was no syncope. So I wanted more information from this patient. So, and her symptoms were fairly frequent. So this was in a 24-hour Holter. So as Javed sir rightly pointed out, we always look at the time during the Holter. So this was at 9 p.m. when she was awake and probably just had her dinner, and she was just walking. So I want you to tell me what have I encircled? Is that a blocked atrial ectopic? Is that high grade AV block? Or is that a sinus pause?
Again, no takers.
Okay, I'm not sure if my questions are too difficult, but I would encourage all of you at least to give a try, so that it would direct you in a particular line of thinking, be it wrong or right, and you would know how to go back or deviate away from that line of thinking. So this is in fact, if you measure these two PP interval, this is sinus, and we know that she had a 2:1 AV block. So this sinus PP interval and this PP interval is definitely shorter. So this is an atrial ectopic which has blocked, and this interval is definitely longer. So this is the post extrasystolic pause. So this is in fact a blocked atrial extrasystole, it also shows that the conduction system is diseased. At the heart rate of say 150, she is not able to conduct. So we in fact did an EP study for her, and this is the baseline intervals. As I told you, the atrial. I would like to direct your attention to the markers which are shown as his distal and his proximal. So you can see the A, the H, and the V. So when we started pacing her at a rate of 110, you can see the first beat, you are having the A, H, V. I in fact darkened out the H so that you can actually make it out. And then the AH blocks. Then again, you can see the AHV, and then there is AH but no V. So this is in fact a 2:1 infrahisian AV block. So this is what we see with most of the Mobitz type 2 AV block. Most of the Mobitz type 2, say around 75% of them are an infrahisian AV block, and probably 25 are intrahisian. The disease is within the bundle of His. But in both the cases, the disease is below the AV node. Whereas in Mobitz type 1, most of the disease is above the bundle of His, is either within the AV node, which Javed sir told that your vaguely mediated winky whacking which occurs during sleep is probably just a vagal phenomenon which is acting on the AV node. So we did left bundle pacing for her, and this was the ECG. So you can in fact see that with the left bundle pacing, the incomplete RBB had corrected in her. So 2:1 AV block, I think Javed boss also told to you how to go about that. So this is the ESC guideline which say that pacing is indicated in patients with third degree or second degree type 2 AV block, irrespective of symptoms. So if you have a Mobitz type 2, you can definitely go for a pacing even if the patient is not symptomatic, because as I told you, most of the block due to a Mobitz type 2 is below or within the bundle of His. And in a patient with a second degree type 1 AV block, which causes symptoms or is found to be located at the intra or the infrahisian level at the during EPS, you are probably two-way indication. So in a patient with a 2:1 AV block where you're not able to determine whether it's Mobitz type 1 or type 2, you look for the history of syncope. Definitely give priority to that history. Make sure it's not vasovagal. If the patient has a baseline bundle branch block, be it right bundle or left bundle, that again indicates that there is some disease below the AV node in the infrahisian conduction system disease. And you can do a Holter or a TMT to look for the Mobitz type 2 AV block, like in our patient. And you can do an EP study also to demonstrate that the block is at the infrahisian level. So all these information give us justice that we are doing something for the patient and she will be relieved of her symptoms. So this is the fifth case, a very interesting case. So the 55-year-old female with history of a pacemaker, permanent pacemaker, single chamber pacemaker, which was put 6 months back for intermittent complete AV block. So this was the record which I got from the previous physician. And the coronary angiogram was done at that point. It was normal. And there was a normal LV function apparently at that point. And now she was admitted with pre-syncope and breathlessness. So this was the ECG. So this is an ECG based question. So I want you to tell me whether this is a paced ECG or is a patient having VT. So it was a single chamber pacemaker 6 months back for intermittent complete AV block.
So house is undivided for paced ECG.
Okay, I think undivided for paced ECG. So you mentioned all of them have chosen paced ECG.
Yes.
Okay. So this is in fact what the ER physician also thought, but there are some clues why this definitely cannot be a paced ECG. So when you see the lead 1, you have the first, second, third beat and the fourth beat. So before the fourth beat, you have a P wave. So that is something what we call a capture or a fusion beat. And again in lead AVF, fifth, sixth, seventh, eighth beat. So you have a P wave. So that is a capture beat. So you have these two capture beat and a fusion beat. And to call it a paced ECG, it definitely looks the morphology V1, V2, V3, it's an LBB morphology. But a very important point, if this was a permanent pacing lead, so you can get an inferior axis which is directed 2-3 AVF, which is positive, if the lead is placed in the RV outflow. So most of other pacing is either done in the mid septum or apical septum, where 2-3 AVF is negative. But you can in fact get a 2-3 AVF positive if you place the lead in the RV outflow. But you can almost never get an ECG, a paced ECG, which is having a QS pattern in lead 1 or AVL. That can never occur. It means that the beat is coming from the lateral wall of the LV. So this itself, the lead 1 Q wave, the lead 1 AVL having Q wave, can only occur if the patient has a CRT. This was a single chamber RV pacing. This can never be a paced ECG. So this in fact was a slow VT this patient had. And this was the paced ECG. So this is to show you that the 2-3 AVF are inferiorly are negative, meaning that it was an apically placed lead. Activation is going away from 2-3 AVF. And you can see lead 1 and AVL, they are not negative. It is positive. But V1 to V6, you can have any kind of morphology. So always direct your attention to the precordial leads, but also to the chest leads when you want to decipher an ECG if it's paced or not. So coming to this patient again, this was a very interesting case. So we were all worried, why is she having this slow VT, which the VT was in fact very incessant. So we put her on Cordron, she did not respond. We had to give Xylocard and then put her on Mixilitine. So this was the ECG after a couple of days when we reduced the pacing rate to 30 because I wanted to see her intrinsic conduction. So what do you see from this ECG? Just to help you out, I'll let you know. So there are two beats. The one beat is always followed by the P wave. That is the intrinsic beat, and then you are having an ectopic beat. So I want you to look at the intrinsic beat carefully and tell me that if the intrinsic beat does in fact suggest that she has a structurally normal heart or a structurally abnormal heart. Because as I told you, the previous physician told me that the echo was normal. So I want to ask you whether you would, from the ECG, you would say whether this it's a normal heart or whether you want an echo. I think that we can start the poll. The ECG also shows some QT prolongation, probably because of the amiodarone which was given to her. But I want to direct your attention to the native QRS.
So everyone wants to get a echo done.
Yeah, absolutely, because the most important part of the ECG. So this is how we look at the ECG for clinical clues. So the V1 to V3, you can see there are deep Q waves. That's not normal. V1, you should have an R wave in V1, which is the septally activation, which is coming from the left side of the heart to the right side of the heart, because the V1 will show the initial R. Whereas you're having deep Q waves from V1 to V3. So it means that she has a dense scar in the septum. So why would somebody, a 55-year-old female who is apparently normal, 6 months in the course, angiogram normal, why would she have a dense septal scar? So let us see. So this was her echo. So I want all of you to see the echo. So those who aren't familiar with the echo, this is a 4-chamber view. This is the RA, this is the LA, this is the LV, and this is the RV. So this is the septum. So as we predicted, there is a dense septal scar. The lateral wall is contracting, okay, but the septum is definitely dense and it's scarred. And again, this is another short axis view. This is the LV and this is the RV. You can just see the pacing lead going in and around here. And again, there is a septal scar. And this is a parasternal long axis view. This is the LA. This is the LV. You can see again there is dense scarring. The gain settings are a little high, but the septum is not contracting at all. So now, I'm sorry, the question. So the echo shows a dense septal scar. The CAG is normal. And I saw the CAG, the coronary angiogram is absolutely normal. And she has a ventricular pacing percentage of 33%. So now we are interested in finding out why this patient who had an apparently normal echo developed an LV dysfunction in 6 months. So is the diagnosis pacing-induced cardiomyopathy? Did the pacing alone cause this entire spectrum of clinical finding? or you think you need more data, you would do a cardiac MRI or a cardiac PET or SPECT. I think once again, my question is, patient with a normal echo 6 months back develops this echo with a septal scar, severe LV dysfunction. Her angiogram is normal, but she was put on a single chamber pacemaker. So we all know that patients on single chamber pacemaker can develop pacing-induced cardiomyopathy. So is this that, number one? Or you think you need more data? You want a cardiac MRI, cardiac PET or SPECT?
So everyone wants cardiac MRI, cardiac PET or SPECT.
Yeah, absolutely. So I think it's the right answer. So the reason being, this septal scar is definitely not normal. You can have pacing-induced cardiomyopathy where you will have global hypokinesia of the LV, but scarring is almost uncommon. So we in fact went because the MRI, we tried doing it because of her device. There was so much of artifact caused by the MRI. So we did a PET and a SPECT because we were suspecting an infiltrative cardiomyopathy. So a SPECT is done just to see the viability of the tissue. So it said that there was severely reduced to near absent systemic EV uptake in the entire septum, whereas the rest of the LV showed normal uptake. And the lower down image, you can actually see the area which is lit up by the FDG is the septum, which is lit up due to the FDG uptake. So she has an active inflammatory pathology with scarring in the septum. And as I told you, her arrhythmia also kept on coming and going because of the same morphology. So it indicates an automatic focus, which again goes to the clinical diagnosis that she has an inflammatory, an automatic pathology which is causing her symptoms. So this in fact was a cardiac sarcoidosis. So the patient did well with immunosuppressant. So what are the clues for cardiac sarcoidosis? So do you do an MRI or a PET in all your patients, or are there specific clues? So number one, in a patient with an AV block for a young age. So young guidelines tell us that young is 60. So in any patient with an AV block below the age of 60, you are justified in doing a cardiac MR to look for scarring, to look for mediastinal nodes. And a young patient with unexplained DCM, you are justified. Young patient with a monomorphic VT, usually an automatic drug-resistant VT. But young patient, which Javed told us, you have the most common form of VTs in young patients are idiopathic outflow tract ventricular tachycardia, which are very, very amenable to ablation. So that's a completely different subset. You identify them by their morphology. So apart from that, and when you have pleomorphic PVCs, PVC is a different morphology. And in any young patient who has any permutation or combination of the above three presentation, meaning you have an AV block with DCM, you have DCM with monomorphic VT, or you have AV block and VT. So this you again suspect for a cardiac sarcoid. In many cases, you're not able to do a cardiac MR because that's the most accessible investigation in your center because of the most of the patient have a pacing or a pacemaker lead. So at least what, as a practice, what we used to do is we used to do a screening echo where we used to look for basal septal thinning. It's a very specific marker for cardiac sarcoid. And we can also try in very clinical condition whether the AV block is steroid responsive, but it's just a hit and try. So in our center, if an MRI is not available, we at least do a screening CT of the chest to look for mediastinal nodes. Because if there are nodes available, you know that you're dealing with a systemic sarcoidosis where cardiac sarcoidosis is also involved. And if an MRI is not available, but still we have a high suspicion, like in a previous patient, we definitely go for a PET. Because in some cases, if the scarring is not very significant, if it's more of an inflammation, steroids can actually save these patients. We've had patients when we were in Jayadeva hospital. We've had many patients whose echo LV function returned to normal, who had very different difficult drug refractory VTs, which was treated with just steroids, immunosuppressant, and probably sympathetic denervation. Because ablation in these patients, again, you're creating a focus of inflammation and scarring, so that can again trigger arrhythmias in such patients. So you should have a very high index of suspicion. So evaluation for sarcoid, look for a scar, LGE, particularly a septal scarring, full body PET for metabolic activity, a cardiac SPECT for perfusion defects, transbronchial lymph node biopsy, because you need histological confirmation also. So if any area which show activity, particularly the lymph node, the mediastinal or the supraclavicular, you can get a biopsy and your diagnosis is confirmatory, and then treat them with immunosuppressant. So our previous patient, she's doing well with immunosuppressant. I couldn't, she actually requires a dual chamber pacing, at least, or a left bundle pacing with defibrillator device, but because of lack of finances, we couldn't go ahead with that. So, patient, different kind of patient, a 63-year-old antral MI, history of an antral MI with complaints of recurrent palpitation. He has a CRTD, which was put for a complete AV block. So antral MI, palpitation, his AV conduction, anterograde A to V is knocked off. It's complete AV block. So he comes with this rhythm, and he doesn't receive any shock. It's a CRTD. So, so this is the ECG which he comes with. And just for information, this is the baseline ECG. As I told you, when you have a biventricular pacer, when you have a CRT, you can have Q waves in one NABL. They indicate that you're activating the lateral wall of the LV. Your activation is starting from there. So this is normal for a CRT. The QRS duration is fairly okay. It's around 100 seconds. The patient is definitely not a responder because his LV function is low. So the question is this again. So the left one is the paced ECG and the right one is the tachycardia ECG. I want you to tell me, is this a pacemaker mediated tachycardia number 1? Number 2, is this a VT or is this an SVT with aberrancy?
So the house is divided between VT and
SVT
with aberrancy.
Okay.
For B and C.
So number 1, if I had made the question as okay, sir. So one thing, I told you this patient had an AV block. So his A to V conduction cannot occur through the normal axis. So SVT with aberrancy is something which can never occur in a patient who has a documented complete AV block. It could either be a pacemaker mediated tachycardia or VT. In this patient, you can actually see these two waves. These are the AV dissociation. So though the pace ECG and the VT looks very similar, this was in fact a VT. And this was his sector. So going on to the next part of the case and the clinical scenario. So this again shows a 4-chamber view. This is the LA and the LV. It shows a dense anteroseptal and an anterolateral scar. So the pranasternal long axis, you can see a scarring across the entire septum, even across the anteropical lateral part of the LV. So this patient also had slow incessant VT. He actually did not receive any shock because most of his VT rates were slower than the programmed limit for which shock was programmed. For example, you set the shock in a patient with CRTD as 170. Most of his VTs were in the range of 150 or 140. So they were only detected and the patient was symptomatic for them. He didn't have a syncope, but he felt uneasy, but they weren't shocked. So we gave him Cordron, we gave him Xylocard, we put him on Mixilitine, we gave him stellate ganglion block, and the VT was incessant. And just another fact, all the VT had the same morphology. We just slowed down the VT, but the morphology was exactly the same. So we had an angiographic CD. So the lady had a 60-70% disease done in 2018. So, and he was kept on medical management. So my question to you is, next step, do you think that this patient has suddenly developed such a VT storm? So we should definitely rule out ischemia. I would, my first step would be to do a coronary angiogram and stent the LAD if the lesion is progress number 1. Or forget about the angioplasty. This patient requires CAR-VT ablation. He requires only an ablation, no angiogram. So I like the poll.
Oh, again, the house is divided 50-50 between the two.
Yeah. So just to take a recap, the echo, if you see, it's a very scarred lady. This septum and the entire lateral wall is not contracting a lot. You can see the color; it's almost white. whereas the posterior wall, you see it's contracting well, and so it's a scarred LAD. So we felt that even if there's an 80% disease in the LAD, or if the LAD is completely occluded also, you're not going to benefit him in opening up a vessel which is already which is supplying an infarcted territory. So you could argue that there could be some hibernating myocardium. We should do a spec, but all his VT morphology was absolutely the same. It was the same slow VT. It had the tendency of not changing at all. It was never more than a single morphology. So it was scar VT, we were 100% sure. And we took this patient for a scar VT ablation. So the above image is done under 3D. So this dense area. So this is the circuit of the scar, and these are the catheters. So this catheter is within the LV, mapping the scar. This is the ablation catheter, and you can see how the VT circuit is going. So this is the critical isthmus of the circuit, and it is activating the lateral part of the LV and the septal aspect in this way. So we gave our lesion in this region, and the patient was VT free after 3 hours. So scar VT ablation, number one, it's a class 1 indication for VT storms, a patient with recurrent ICD shock due to monomorphic VT. Ischemia can cause polymorphic VT. Very, very rarely you see ischemia causing a monomorphic VT. Infarct always causes monomorphic VT. So coming on to the next case, that's probably the last case. So, and it's an interesting case. So it's a 65-year-old female with acute onset chest pain for 2 hours. So this was the ECG which was taken. So I'll run through the ECG. Sorry for the bad quality of the ECG. So this is sinus rhythm -1 AV conduction. You can definitely see ST elevation in lead 1 AVL with T inversion, prominent ST depressions in V2 to V4. She definitely has some form of an MI, maybe NSTEMI or STEMI. So we took her up for an angiogram, and this was the right coronary artery. So the right coronary artery is reasonably okay, no occluding vessel. And this was she had a critical lesion. This is the left anterior descending. You can see the lady has a critical lesion at this point, and she was successfully stented with this stent. So my question next, what happened to this patient post procedure? This was the ECG. She was relieved of a heart failure. She in fact was intubated during the procedure. We extubated her. She was fine, having her food, and she had multiple episodes of syncope. Say 6 hours after the procedure, within 1 hour, then 10 p.m., 12 a.m., 3 a.m. She had multiple episodes, and because it was in the night, we couldn't actually record the episodes in the monitor, but it was definite resuscitated cardiac arrest. So we connected to the Holter, and this was a short Holter. So it's a very interesting Holter. So I want you to tell me what is happening. So is this, so this is at 4 p.m. So she's not sleeping, she's awake. And during this episode, she had again posturing with syncope. So is this a significant sinus pause, number one? Is this complete AV block? Is this paroxysmal high-grade AV block?
Definitely a very interesting case. I hope.
Yes, sir. In fact, this pause was almost 26 seconds in the Holter. It was, we just saw the Holter report. We ran back to her.
Paroxysmal high-grade AV block.
Okay. I think so. Most of them are absolutely right. And interesting thing about the Holter is just preceding the block. If you see at this beat, this is an atrial ectopic. She was conducting at a rate of say 110 or 100, and a premature atrial ectopic completely blocked the AV node. The AV node is damaged it's not conducting for almost 30 seconds, and then again it recovers, where it's conducting at the rate of 120, 130. So this is a classical paroxysmal high-grade AV block. As Javed boss told, this is the most dangerous of AV block. The patient will collapse within hours if you don't attend to them. Whereas in a patient who has an AV block with a stable escape rhythm, it's okay. You need not put in a temporary pacemaker. But this patient, we put in a temporary pacemaker and we took her up for permanent pacing. The interesting thing is, so this is another Holter which shows that multiple episodes. She had some episodes preceded by the PAC, some by PVC. So I run through the angio. Probably most of us would not have paid much attention. So this was the lady which was had a major septal perforator at that point. So once again, I'll just play both the. So you can see this septal perforator, and post stenting, that septal perforator has no flow. You can see. So definitely, because we were going through her angiogram and we were wondering what whether we missed an RCA lesion or what went wrong. In fact, we did a check angio and the status was the same. The septal perforator had no flow. So now my question is, the AV block, A, is not related to the occluded septal perforator. It's just an incidental finding. Number B, it's most probably related to the occluded vessel as it supplies the conduction system. So I'd like a poll on this. So this is the last question. So I think all of you can
Meanwhile,
relax and answer
the
this.
poll is
We'll
going
take
on. There is
20
a
seconds.
question from Dr. Anuradha from Chennai. When you call a VPC as benign?
Sir?
There's a question from Dr. Anuradha Chennai. When you
Okay.
call a VPC as benign?
When do you call a VPC as benign? Yeah. So there are you have I think some PVCs, particular PVCs of the outflow tract morphology, so where you have left bundle branch block morphology with an inferior axis 2-3 AVF positive, AVR and AVL negative. So that's a classic outflow tract morphology, either an RVOT or an LBOT, and the patient has a significant, you then do a Holter. So the patient comes to you with palpitation, you see the ECG, you have 4 or 5 PVCs on the ECG, you do a Holter and you record the Holter burden. Say you get a burden of say just 5% or maybe just 5,000 beats, then you don't do anything. Just reassure the patient. Just tell them it's an incidental finding. So they are benign PVCs. Number two, when you the same PVC, even if it's an outflow tract morphology, and you have a high burden, say more than 20% or more than 20,000, then you at least need to give them some drugs. And outflow tract PVCs are sensitive to calcium channel blocker or are very sensitive to radio frequency ablation also. You have success rates of around 90%, and they can be targeted easily. On the other hand, so this is in a patient with a structurally normal heart. So they are probably the benign PVCs. In a patient with a structurally abnormal heart, say with you suspect infiltrative cardiomyopathy, you suspect post myocardial infarction, and with symptoms, palpitation, syncope, even a single PVC in a patient with a syncope could, in a patient with an underlying structural heart disease, could be fatal. So, and Javed was also told about some specific markers of PVCs, where PVCs have short coupling interval R on T, or PVCs causing cardiomyopathy. So I think you see the patient as a whole, do a Holter, do the echo, get investigated, find out what substrate you're dealing with, and then you treat them.
Yeah. Coming back to the poll, the house is undivided for not related to occluded septal perforator, incidental finding.
Yeah. So we were also probably thinking about the same. Then I went back and looked at the literature. So there are cases where you can have a jailed septal perforator causing AV block, and those AV blocks are very malignant. So the reason I'll tell you. So blood supply to the conduction system, if you take the SA node and the AV node, are predominantly supplied by the RCA. So when you have an inferior wall MI causing a complete heart block, I'll go back to the angio for the RCA. So the inferior wall MI causing AV block. So your septal, your AV nodal artery probably comes from this region. This is the region where the posterior descending artery and the posterior lateral branches. So the AV nodal vessel will come here. In a patient who has an inferior wall MI and AV block, even if he has a blockage at this point, he will have AV block, but it's a distal part of the vessel. So the quantity of myocardium which is injured is not great. In contrast, so inferior wall MI causing AV block is more common, but they are not more morbid or having more mortality. Whereas in antral wall MI, I'll tell you 1 second. If you say take the bundle of his and the right in bundle of his 75% by the left coronary artery, 15% by both. And if you take the right and the left bundle, they are exclusively supplied by the septal perforators. And if you see which septal perforator, they are usually these two. They are the first, only this large septal perforator which supplies the proximal left bundle and right bundle. So when you have an MI which causes AV block because of injury to this septal perforator, means that you have an occlusion here. That is why when you have an AV block with an anterior wall MI, it's a very, very severe disease. The patient is in hypotension. The patient usually doesn't survive. Whereas in an inferior wall MI, even though it's more common, most of the patient can even recover. So this patient, I feel that the jail septal perforator could have contributed. Maybe her conduction system was already diseased because of her age, and this just brought out a manifestation. So, but the Holter was very, very frightening for us, and we immediately took her, and she's stable. She's fine. She's had no more episodes of syncope. We again did a left bundle pacing because she had LV dysfunction from the MI. She is fine. Sir, you have any cases like this where you jailed a septal perforator and you had?
I don't have, but I have colleagues who even have done septal angioplasty and stenting.
Okay.
They had this kind of problem, and they found that it was a rescue where patient recovered with after the stenting.
Okay. Very, very true, sir.
I think your suspicions are right that this is probably related to.
And another point: most of when the AV node or SA node, they are relatively more resistant to ischemia, be it hyperkalemia causing an AV block or ischemia. They're more sensitive, but the Purkinje fibers are very, very sensitive to ischemia. Once they're injured, the injury is long lasting. So that could be another point why we thought that it was ischemia related. Yeah. Yes, sir. Thank you, sir.
We have one question for you from Dr. Jaideep Das Gupta, Kolkata.
Yes,
is
sir.
Genetic analysis compulsory in all the cases of long QTS? Does indicate?
Yeah. Number one, if you take the scoring for long QTS, genetic analysis is in fact a part of the scoring. It helps you in giving you a definitive diagnosis. Number two, it helps you in managing your patient. You have a patient who has a particular history, a family with a history of a child who has died and a grandparent who has died. They come to you for genetic counseling. You see just a prolonged QTC. So at least because you have the three most common, so almost 80% of the patient, if they have a long QT, they either come in 1, 2, or 3. So you don't have to screen for many genes. So if you have an available center and you are suspecting congenital long QT, definitely I think you should. There are specific ECG findings as Javed boss and I showed you for long QT 1, 2, and 3. And there are certain syndromic associations also. You know, the JLN syndrome where you have deafness, Timothy syndrome where you have macroscopic P-wave alternance. So I think when you're sending for a genetic analysis, you mention whether it's 1, 2, 3, or you have a specific mutation in mind. It's an autosomal recessive you're looking for, Java JNL, or it's autosomal dominant you're looking for Romano Ward, or it's Timothy syndrome. Then you mention so that the genetic analysis also becomes easy. But it would definitely help. For example, long QT3, mexiletine definitely has a therapeutic role. Long QT1, they respond better to beta blockers and sympathetic denervation. Long QT2, pacing offers a therapeutic role because they are very, very difficult patients to treat. And some patients come to you at very younger age. You cannot offer them pacing or very aggressive treatment. But I feel that it would help an analysis.
Dr. Javed, you'd like to add some to Dr. Sanjay's discussion? Or else there are no questions, we will close the session.
Just before closing, Sanjay, did you do a diagnostic EPS for that patient where septal perforator was occluded?
No, but because it was actually done by a colleague of me, the angioplasty. So right. we were sure that she requires a pacemaker, number one, and diagnostic pacing we put, she was extubated, then we had to reintubate her. I measured the HV interval because during the procedure we had a TPI. The HV interval was normal. It was not, I think it was around 48 or 50. But again, during manipulation with the temporary pacing, the PVC would cause her going into AV block. In some at some points, her sinus rate in itself was at the rate of 120. But at some point, just the PAC or PVC would cause her AV block. So it was very bizarre.
Okay. Now, would have been interesting to know what about VA conduction? Was VA conduction also same intact?
VA conduction was, I'll go through the traces, boss, because yesterday
Okay,
only we
okay.
had done the
We can
case.
have a different
I'll go through the
discussion.
case.
Probably we should close it now. It's too late.
Yeah.
It was a very,
I'll
very
just
good,
stop sharing my screen, sir, once again.
very good discussion. And Dr. Sanjay's presentation, it had many learning points. That is what we can judge from the poll results also. So definitely it was a great learning for all of us present here. And I thank Dr. Javed and Dr. Sanjay, and I hope that we'll have part 3 very soon.
Surely, sir. In the month of August, we'll decide and do a part 3,
Yeah.
and we shall have to decide on what topic we want to do it. It would be based on ECG as well. We'll see, sir. Sure.
Yeah,
Thank you,
because
sir, for always joining us and always encouraging us.
it's a
You
learning
find time to
for all.
you always find time to join us. So
Because
that was very
you both
heartening.
so well that I have to be here.
Okay.
Right here.
Thank you, sir. Thank you so much, sir.
Thank you, IPCA, also that you have arranged it so well. And last time we had few hassles and they have been cleared this time.
Yes, sir. Yes, sir. Yes,
That's
sir. Yes, sir. So once again, sir, good evening to all of you. On behalf of Team IPCA, I would like to take this opportunity to thank you all, especially Dr. Smith Srivastava, Dr. Javed Parvez, and Dr. Sanjay Vivi, for this wonderful and a very useful case-based scientific discussion. At the same time, sir, I must take this opportunity to thank all the participants and viewers for making this webinar successful. Once again, thanks to all of you, and we will definitely go for another series, that is series 3rd in the month of August, as you are discussing. Thank you. Thanks to all of you, sir. Thank you.
Thank you.
Oh.
Thank you. Thank you. Thank you, Javed. Thank you, sir. See you.